Welcome to this educational video brought to you by the Society of Mechanical Ventilation. Intermittent Mandatory Ventilation. IMV-SIMV.
Hi, today we'll talk about an old mode that's still in use, pretty controversial. Um, anyway, we'll jump into it. It's about intermittent mandatory ventilation, IMV, also known as most commonly as SIMV. We'll try to talk a little bit about the history, clinical application, and some controversies about this mode and some of the advantages and disadvantages about IMV. So the definition of IMV, if you look at the breath sequence of any ventilator mode, according to Shadburn's classification, are one of three: either continuous mandatory ventilation, CMV, where whether the patient triggers it or the ventilator triggers it, it will be the same kind of breath. Continuous spontaneous ventilation, meaning the patient triggers and controls all the breath. And in between, we have the intermittent mandatory ventilation, where there's a set mandatory breath, and in between, the patient can have his own spontaneous breath. If you look at the definition in the literature, it's intermittent mandatory ventilation refers to any mode of mechanical ventilation where regular series of breaths are scheduled, those are the mandatory ones, but the ventilator senses the patient effort, so those are the spontaneous ones, and reschedule the mandatory breaths based on the calculated need of the patient. And that's why the term came synchronized intermittent mandatory ventilation, SIMV, which is more commonly used these days. So as we talked before, SIMV is an old mode, been incorporated probably in ventilators in the 1972. This is an article published in our Journal of Mechanical Ventilation in December 2021, which talks about the history of IMV prior to 1971, and will be followed by part 2 in early 2022. So when SIMV was initially incorporated in the first mechanical ventilation, probably called the baby bird, it basically revolutionized mechanical ventilation, because at that time it was all continuous mandatory breath, and different from continuous mandatory breath of these days, the patient cannot trigger. So if you put different specific rate and volumes, the patient has no choice. Even if he tries to triggers, he'll only get the mandatory breath. But now with SIMV, for the first time, the patient can have his own spontaneous breath. So the mode evolved over the years. In the beginning, there was no pressure support for the spontaneous breath. Now there's mostly used with pressure support to support the additional spontaneous breath. Now it could be used in the volume controlled mode with pressure support, in the pressure controlled mode with pressure support, and in the adaptive modes like PRVC with pressure support. And it's very important to know the ventilator that you are using, because some of the ventilators have many different SIMV and SIMV pluses that might act different from our regular understanding. And there's 4 types basically of IMV. IMV1, which means that the intermittent mandatory ventilation rate are always delivered. So if you set the rate at 10 and the patient is breathing 16, he will get 10 mandatory regardless. IMV2, the spontaneous breath will cancels or suppresses the mandatory breath. So again, if you set the rate at 10 but the patient is breathing above it by 16, he will be only getting 16 spontaneous breaths. Type 3, where actually if the spontaneous breaths are surpassing the minute ventilation, there will be no controlled breath. So if you set, for example, tidal volume 400, rate of 10, so that's 4 liters, but if the patient's own spontaneous breath are above that, it will be only spontaneous breath, no mandatory. And type 4, which I think it's only on one ventilator, probably the servo, it's dual targeting where it changes the cycle variable according to the patient. So again, please be careful and read the manual or notice what your ventilator does because it might be different in different ventilators. So because of the controversies that we'll talk about in the next couple of slides, I'm one of the people who used to say, why would I use SIMV? It's an old mode, we have better alternatives. It's shown to delay weaning. So I've been also guilty of, as soon as I see any patient on SIMV, I would just switch it. But when you dig more in the other modes of mechanical ventilation, and this is a paper from respiratory care from Shadburn about the taxonomy or the names of mechanical ventilation. And here are multiple examples. I know it's a very busy slide of different ventilators. And if you look at the modes, I put the arrows here that has IMV, uses IMV. So of course you can see SIMV, SIMV, so of course those will be SIMV. But you look at the other modes that we use, like bi-level is an IMV, APRV is IMV. Here in the Draeger mandatory minute ventilation is IMV, with all those, and the list goes on and on, APRV, even ASV and AVM, all those in new intelligent modes, they can be IMV too. So as you can see here, ASV, adaptive pressure ventilation, SIMV. So anyway, based on this example, if you look all of these orange arrows, IMV is still alive, but in just under different names. So why would people use IMV or SIMV and when? Originally, the studies looked more at weaning the patients from mechanical ventilation, and the idea was to start some controlled mandatory ventilation, then slowly, gradually decrease the mandatory breath, and to basically shift the load from the ventilator to the patient. But in the late 90s, as we'll talk later, most of the studies showed that it might actually delay weaning. Also, to reduce patient ventilator dyssynchrony, again, that's mostly in the past. At that time, again, there was a patient couldn't really trigger the ventilator, but now we have better modes, or even spontaneous modes are better. Question of comfort, yes, you don't have to sedate the patient too much because he can do his own spontaneous breathing. You can use this full support, and of course, even if the patient is totally passive, like chemically paralyzed, it will be just mandatory breath, so similar to volume control or pressure control. And some people use it in long-term ventilation places like nursing homes and chronic ventilation. So we'll start here with our simulator. We're using the Hamilton G5 simulator, and we'll go to the modes. And in this simulator, we have, it's written here SIMV, which is the volume controlled, and there's the pressure SIMV. And we'll show you in another simulator how to use the PRVC or adaptive SIMV. So we'll choose the volume control SIMV. Okay, and the controls. So on this side, rate, that's a mandatory breath. Each breath will be, I put here the rate of 10, tidal volume 500, the PEEP, FI2 like you usually do in any controlled mandatory ventilation. You can use the I time or the flow rate if you want to put any pause, the trigger. And here are the spontaneous breath. You can use pressure support or you can't. So if you don't want the patient to have any support, you'll go 0. If you want to add some pressure support, up to you. The flow waveform, this is for the mandatory breath, the rise or the ramp, and the ETS or the expiratory sensitivity, as we talked in the video of the pressure support, you can dial it because this will alter the cycling of the pressure support, only the spontaneous pressure support. So we'll keep it at 25. Okay, so this patient is passive. So as you can see, the ventilator is giving rate of 10, all volume controlled, square waveform, and that's the airway pressure and the tidal volume. So it's basically exactly controlled mandatory ventilation. So we're gonna start making our patient breathe a little bit higher at a rate of 15, and let's see what happens. So you will then start seeing eventually the patient will start triggering the ventilator, and we'll start noticing some of the spontaneous breaths will be pressure support. And just for ease, I'm just gonna drop the mandatory rate. So if you can start seeing here, this is the volume control, and this is the ramp, the descending ramp of pressure support. So this was a spontaneous breath. Again, here the ventilator gives you the arrow that's spontaneous, and you can see the difference between the controlled, volume controlled square waveform and the spontaneous pressure support. And again, you can increase or decrease the pressure support. Let's increase it so you can see the difference, just to be obvious. So of course you're gonna see the pressure became high. I dialed 15/5, so, or actually 17, so the pressure goes very high here. And of the volume control, it's bowed like this because of the patient effort. So that's an example how you can do it. And as people use it in weaning, they keep dropping the rate until eventually like 1 or 2, then the patient is totally in pressure support. Let's see the pressure SIMV. Very similar, so we'll dial it as regular pressure control. We'll put a rate, we'll put a driving pressure, whatever you want. Here it's 15, people 5. The trigger, the same, and the amount of pressure support. I put here pretty high pressure support again, so we can distinguish it from the pressure controlled ones. Same idea, ETS and the ramp. And we'll say okay, and we'll make that patient again a passive patient, not breathing, doesn't trigger. And again, we'll notice now that because this is pressure controlled mode, it's a decelerating waveform. The patient is not triggering anything, so the rate will drop down to 10. And once we start making our patient breathe at a rate a little bit higher than the 10 here, I'm just gonna drop it a little bit so you can see the difference. So as you can see, sorry I can't freeze this one, but you can see the difference. The pressure will be higher because I put the pressure support at a very high level. So those are pressure supported breaths, and you can see it terminates at 25% of the cycle. And you can, again, I know the flow waveforms look a little bit similar because both are pressure controlled modes, so they use similar pressure, but you can see the difference between the controlled mode and the spontaneous breath. So the ventilator here will still give the patient every minute 7 controlled breaths, and the rest, patient's breathing 16, he will be getting the extra 9 as pressure controlled here. So we'll drop the rate down to 3, but again the patient is breathing 16, so the total will still be 16, but 13 of them will be spontaneous and 3 of them will be pressure controlled. So that's why I'm saying it's very important to know how your ventilator works, because not SIMV in every ventilator is the same. Alright, so this is another simulator, also of the Hamilton, but the C6. And I just want to show you the SIMV APV, or APV SIMV, which APV meaning adaptive pressure ventilation, or also known as pressure regulated volume control, PRVC. So we'll choose this. Then we'll go to the controls, same as we talked before. You can set the rate. I'm just gonna make it a little bit low. Set the tidal volume, the PEEP, the FiO2, again the inspiratory time, the flow trigger, the amount of pressure support, and I'm gonna make it here a little bit high so we can distinguish it from the mandatory one, the pressure ramp or the rise, and the expiratory sensitivity. And we'll say okay. And now you will see, actually, want to show you the difference here. So as we know, in PRVC, the ventilator will adjust the mandatory breaths, will adjust the pressure up and down to achieve the tidal volume that you delivered. So if you see here, okay, so this is the mandatory breath. Yes, it's triggered by the patient, but it will still give him at least 7 mandatory breaths, and it tried to adjust the pressure to get the tidal volume here 513. Versus this was like a pressure support one. So you can see the pressure here is higher, 23, because we dialed 18 over PEEP of 5. And you can even notice the difference in the flow waveform. This cycles here at 25% of the peak inspiratory flow versus this one. The mandatory one is 1 second as we dialed. And you can see the pressure, airway pressure, of course, they're both pressure controlled breaths, so they look like the same except in the difference of the amount of pressure. So this is basically, again, I just want to show you this to show you that IMV can be used in the APV mode. And while we're here, also I want to show you that how ASV also can use IMV, and we have a specific video for it, so I'm not going to go much in details. So we'll do this layout to we can see, as you can see here, this patient, the ventilator wants a rate of 18 with a tidal volume 450 right now. So there was some spontaneous breath and some mandatory breath. As you can see here, the controlled one are 7 and the spontaneous are 11. So this means by definition it is an IMV mode right now because the patient is partially doing some of the work. The only difference in ASV is now you don't dial a certain pressure support like you do with the regular SIMV, because the ventilator will control the spontaneous breath, to control the pressure, try to achieve the tidal volume. So when it comes to advantages and disadvantages of IMV, one clear thing that has been consistent is that when used for weaning or liberation for mechanical ventilatory support, it should to be prolonged the process and to be a little bit worse than pressure support ventilation or TPs or CPAP. But also those studies, although they were very big studies, but they were at the end of 1990, so very old studies. We know that our use of mechanical ventilation is totally different at this time. So I put that check mark here because it is probably disadvantage. But when you look at acid-base balance, work of breathing, asynchrony, most of the studies there are not really convincing. They're small studies and old studies again. So that's why I put check mark, because it's really unclear if SIMV is really worse than any other modes of mechanical ventilation. And I will put some references at the end of this lecture about that debate of SIMV in general. So we'll conclude with some references. I think this is the one that we talked about in the Journal of Mechanical Ventilation, the first part of the history. This one is from Respiratory Care, saying, is SIMV time to send this workhorse out to pasture? Similar, this one also from Respiratory Care about should intermittent mandatory ventilation be abolished? And that's also a good article because it has pros and cons for and against it. Those are the old study, one of the famous study by Brochard about comparing three methods of gradual withdrawal, ventilatory support, which showed that IMV was delayed weaning. And that's one of the taxonomy of mechanical ventilation that we mentioned about in the video. So to summarize, I really can't say is SIMV any superior or any inferior than other modes. Unfortunately, in the science of mechanical ventilation, we don't have many comparisons of modes, and I think we should have more studies about comparing modes. Is there is one more superior than the other, or is one really inferior? We should use it. Most of our studies are small. Some of our opinions are really anecdotal. So it makes the decision of which mode to use is a little bit tantalizing. With this, I would also say the mode is as good as how you use it. So if you use it good, then you might be okay. But even the best mode there, if you can use it wrong or bad settings, it could be dangerous. And so that's my conclusion. Thank you for your time, and I wish you all Happy New Year.